right, so from an introduction standpoint, introduce yourself and tell us about your background.
So my name is Saju Joseph. I'm a general surgeon. I'm trained in general surgery as well as complex foregut surgical oncology. My background, I did residency, medical school in Boston, residency at Harvard, fellowship in Scotland, under the Royal Infirmary in Prough Garden and in Edinburgh. So kind of unique background from a surgical standpoint.
So I want to take this conversation and go follow your history of practicing, but then how the evolution of this has gone. So you're at your residency, you're in the hospital setting. What do you go back and think about from back then?
So the thing I probably fall back, the great part of training at Harvard is you're working with world experts nonstop, right? Consistently. But the thing you learn from them is technique, absolutely, but more importantly, identifying true symptomatology. What is a symptom? What's the disease? And addressing the disease. And you know, most surgeons have become kind of, mechanics. They just do the thing they know how to do. And the reason you see these failures is because I say the cognitive aspects, right? They don't think about the patient and the disease. They think about the symptom.
So let's go example, because we were talking about hernia as an example. So infection rates, it is a high frequency, so
Super
not
high.
a big cost,
Nope.
But a high frequency. Talk to us about the variance of something like a hernia.
Yeah, so hernia surgery is the best example. Super common operation, higher than should be expected complication rate. So you look at the total recurrence rate, wound infection rate, all these other things, you add them all up, and you're at about a 20%.
So
lifetime.
1 in 5 people
Will fail their surgery.
will have a failure.
Yep.
And in a normal model, failure means doing it again.
Doing it again, more likely a failure, super high cost, right?
So in that scenario, the cost, the complications, it costs an employer, thousands and thousands more. What's the alternative?
So the way we approach hernia is, again, back to a symptom, right? The hernia is a symptom of an underlying disease process. Obesity, muscle weakening, microvascular disease, the diabetics, the smokers, things like that. So we approach it very differently, right? A, we are very specific on the patients that should get the surgeries. B, of the patients that get the surgeries, we ensure that we address the underlying symptom. If they have microvascular disease or muscle weakness, we use regenerative medicine techniques to increase blood vessels, increase the muscle strength. If they are smokers, we stop smoking, we encourage improved activities. And then in the patients who have high risk of infections or high risk of recurrence, we have multiple products, not just a cutting-edge mask that's biologic that would normally run an employer thousands and thousands of dollars that we get at a much lower rate, but also wound care products that help stimulate the wound to heal.
So you're saying we in this scenario, so you used to practice in hospital settings and now you're part of an ASC group.
Correct. So we have a large surgical group. Our group is Valley Oaks Surgical Group. We do a broad range. So I do general surgery, mostly the biliary and the hernia surgery. My partners do some of the hernia surgery as well. They also do endoscopy. They do a lot of the kind of outpatient cases, and then a lot of the cases that used to go into the hospital, we can do on the ASC side. When COVID hit and all the hospitals shut down, we moved a lot of that practice to the ambulatory surgery center, where if you needed a 1 or 2 day stay in the hospital, we just kept you in our recovery suites and were able to care for you there.
So for the person who is visual and never seen an ASC, give me the visual of what an ASC is.
So the simple version I tell my patients, imagine you have an operating room here, and right next door is a hotel. But that hotel also happens to have nurses and lab services and a pharmacy. And because we can recreate the things you would need in a hospital and we recreate the surgery in a much more efficient, much more cost-effective manner with better outcomes, we can take care of you inside of simply what would be the equivalent of a hotel, right? It's a room, a bed, there's people taking care of you, there's doctors there. You're getting basically hospital-level care, but you're getting it inside of a very private setting.
So let's go back to the hernia example. You as the guy scrubbing in to do it, what's your experience difference when you go into the hospital to do it versus when you do that in your own ASC?
Yeah, so our own ASC, right, we're a fine-tuned machine, right? I got my same scrub nurse, I got everything is set up in routine. You walk into a hospital, number one, you're walking in with 50, 100 other people, like in the pre-op holding area, to the operating room, to the recovery room. Even if you're going home the same day, you're being exposed to 1,000 kind of infectious vectors, right? A hospital is a very unsafe place for a otherwise healthy person. In the ASC, we don't have that. It's 3, 4 people. It's a very streamlined process. We have the mesh, the sutures, everything is down to a science, and we just move efficiently.
So more efficient process. So you're in there, you're doing your deal. Shorter amount of time? Like, talk to me about that like the actual, you're in there doing the deal.
Very short. So, these types of cases are 30 minutes, 40 minutes, as compared to an hour and a half, 2 hours in the operating in a hospital, right? And most importantly, just safer, right? You're not being exposed to the bacteria and the viruses that are inherently present in a big hospital.
Well, and I got to think, like, me under anesthesia for less amount of time, that's just healthier for the patient.
100%. And some of these are things we don't even need to give you significant anesthesia for, right? Smaller things we can do, like, just with a little sedation. Almost. Yeah, and you're awake, but we fly through it quickly and efficiently.
So, most surgeons aren't going to know, like, the cost of it, but now that you're an owner in this, you probably know the unit costs and things. Yeah. Talk to me the cost difference between the hernia in the hospital and the hernia in your ASC.
The simple version I tell patients, 1 digit. If it was $50,000 at a hospital, $5,000 at the ASC. It is an entire massive difference.
55.
Correct.
Okay, so, but you're doing each.
Yep. Same operation, same patient.
Same person, same surgeon.
Same surgeon, same everything.
So, any logical person would look at those two things and then ask the question, why? Why would somebody trained in Harvard, Scotland, did all of those things, why would you take 10%? Are you making, like, talk to me about the economics here.
The hospital makes more, right? But the surgeon does not. The surgeon gets paid the same amount, whether I do it at the ASC or at the hospital. The reason we want to do it at the ASC is because we have better outcomes. The difference is in the hospital, payers are paying for the uninsured patients. They're paying for the emergency room that's sitting there open. They're paying for the other operations that don't make them enough money. The hospital raises the price to make up for the losses they've had on other things.
So if you're sitting with a employer, an advisor, somebody, how do you have this logical conversation? So, like, I obviously do this every day. I know the conversation. How do you have that talk track with somebody?
So generally, I don't do it as often as you do, for sure. When I do, they're often patients or have loved ones.
So let's talk about a patient. Yeah, that's great.
So a patient or a loved one. And what I explain to them is that they can get the same level of care, right? Because most of them are post-operative patients that I've operated on, right? And they're looking at their bill, right? And if they're an employer who's higher up in the company, they're looking at their bill carefully, right?
On both sides.
On both sides, right? And they're saying why, and we are happy to share our prices. We put our prices on our website and say, this is what we, you want to pay us cash. This is how much it is, right? And so the smart employer is sitting there saying, well, why did my insurance company pay all of this when I could have gotten the exact same surgeon, same patient, same outcome, if not better outcome, at a lower cost? And I tell them, you should talk to your bosses about why that is, because it makes zero sense other than the fact that, right, hospitals have to find a way to find this money, right? And so they're going to upcharge the people who have it.
Right. So last question here, so we talked about hernia, right? That is a spectrum. If we talk about the 100% of things that can be done in a hospital versus an ASC? Are we talking about 10%? Are we talking about 80%? Like, what's the percent? 80.
Yeah, so there's probably close to 500 to 600 CPT codes that we can do in the ASC.
So for the average layman, that is something that happens to me. A CPT code, something that's happening to me. Right.
In general surgery, there's probably about 1,000 CPT codes that, give or take.
Okay.
We can do a good 600 to 800 of them in the ASC center at a tenth of the, at one entire digit lower cost.
So this will be my last question, I promise. You're talking to an employee in that scenario. What should they do to be proactive with their own care? Because, what you told me is, hey, it's safer, it's better outcome, it's cheaper, da-da-da-da-da-da. But if I'm only listening to my doc, my doc works there, so what's the questions that the patient should be asking in that situation?
So I think the patient, especially nowadays, are smarter, right? They need to know what are the risks, what are the complications. They need to know what the different alternative options are. And then I think they also need to start thinking about where is the cost, right? And most employees think only of their deductible, right? Not their total cost of what the care is going to be. Ironically, most of the time now, I have patients who their deductible is more than they would have paid just straight out of pocket. And so those employees need to start calling their, HR benefits people and saying, what is this?
What are we doing?
What are we doing, and why can't we do this better? And nice thing, a lot of the smarter employers are getting to realize they are just paying astronomical costs for no outcome. And COVID's the best example. You look at the number of patients who came into a hospital with one thing and walked out with COVID or died in the hospital because they got COVID. That right there is the easiest way to sell it. When patients are looking at me, I go, dude, do you want to be in a hospital and get COVID and die? You feel free. Like, I'll take you there right now, right? But every one of them was like, Doc, I want to stay as far away from that as possible. Can we do this right in your office? And I'm like, yeah, there's an ASC right there.
Cheaper, better outcomes, safer, same surgeon, lower unit costs. Yep. There's no downside.
No, and in general surgery, the denominator is so large, right?
It is 70% of the costs, or the transactions that are happening every day.
Correct. Every day. And to lower your complication rate even by 5%, which is nothing, is such a dramatic cost savings to every employee.
Man, well, thank you.
Anytime. Pleasure.